The thoughts and opinions on Just Some Podcast are of the hosts and guests and do not represent the views of organizations that employ them or they volunteer for. They are also not responsible for spontaneous black holes or nuclear wars that may occur. You have been warned.
Welcome, everybody, to another fun-filled and exciting episode of Just Some Podcast. This is Tom.
Hey, this is Ben. Tom, how's it going, man?
It was an exciting day. I can't get into a lot of the details. For a family office, it was action-packed. It was like Die Hard meets Jurassic Park. Huh. Yeah, it was that level of excitement meets a math exam. Like, it was like, then it comes back down. Like, it goes that, no, not a rectal. So...
I said pterodactyl. I said pterodactyl, not rectal. Wow.
Yeah, it was that type of day. How was it in your neck of the woods?
You know, it wasn't too horrible. We're still rocking through a bunch of those well-child exams because everybody's gearing up to go to school. My girls go to school tomorrow, so they're actually in bed now. So good times, and we'll see how that goes. But Tom, we do want to bring on our guest. We get him in here to have some fun with us early. So we want to welcome Brad to the show. Brad, how you doing?
I'm fantastic. Thanks so much for having me.
We appreciate you being on despite all the technical difficulties. We've been trying to record for about 45 minutes now, and we're just now ready to go. So
that's how I knew he was going to be fun. He took that like a champ and kept us laughing. So I was like, okay, this is going to be a fun show. I'm going to appreciate this. So.
Yeah, which is the least stressful part of our days, I think.
Absolutely.
You got to enjoy it.
Yeah, trying. And until I find a way to mute myself somehow. So that's always fun.
But Brad, how was your day?
It was good. It was good. Nothing really notable happened. You know, woke up with the kids, went to the office. Today was my surgery day, so I had a couple surgeries in the morning, then went for office hours in the afternoon, and then back home to the kids, put them to bed, watched a little West Wing with the wife, and reruns from, I guess, 20 years ago now. And now here we are.
It has been, yeah. Wow.
I would say West Wing was like one of my all-time favorite shows, old President Bartlett. So that was a fantastic show. What made you into West Wing? Are you a political junkie or you just happen to like it?
So I watched it when it was reruns, because when it was on, I think I was in college. So I didn't start watching it until medical school. I think it was because one of my roommates was into it, and I watched it, and it just made me want to be better. You just see everyone on that show is just so smart and engaged and awesome, and you're like, I wish I could be like that. And I just feel like it always inspired me to like do a better job at whatever it was I was doing. And now my wife, who actually didn't grow up in this country, so she didn't see it, I introduced her to it, and I walked into the room. I'd been with the kids putting them to bed, and I walked downstairs, and she had put it on. So she's getting back into it. Maybe because we have an election coming up. I don't know. Probably,
yeah.
I would say I agree with you. Like that whole show, every time you watch it, you're like, wow, it would be so amazing to work in the White House. So every time you watch an episode, like something awesome happened. And I always thought that was great. I've always been into politics, though, so that was a fun show for me to watch. And I'm like, that'd be pretty cool to work in a place like that.
Oh yeah. Although they're just rapid fire dialogue. Like I don't think human beings actually talk to each other like that. I'd be pretty intimidated. It's just like so fast and so clever, and they just have so much information at their fingertips.
I interned for a congressman in college, and I will tell you, I don't remember anything that super cool. I mean, I got to do some very interesting things. And I was part of some decisions. I was like, I can't believe someone's asking my opinion on this. But at the same time, like you said, when you're watching West Wing, I'm like, no, you sit around for like 45 minutes typing something, and then in 4 seconds they ask you yes or no, and that's that's the decision. So I'm like, oh, okay. So that's how it really happens. Is you're like, I'm going to make this great argument. And they're like, just tell me what we're doing. You're like, yes. And like, okay. And then they will walk forward. You're like, oh, all right, never mind. So that's how the government at the lower levels actually played part in my experience.
Who was it that you worked for?
A representative out of Hawaii when I was at University of Hawaii. So it was actually at the state level. It wasn't US level. But when I talked to other people at the, from the congressman's office, because I talked to them, I even Speaker of the House, like I met people from all over the place, and they're like, no, it's like this, just way bigger. I think honestly, and this is going to sound dumb, and this is how you know it's true, the most impressive thing were the Xerox machines. They had Xerox machines the size of like most people's bedrooms. And if you needed to print out 12,000 copies of a 100-page binded manual, you could do it in like 5 minutes. It was the most amazing thing I'd ever seen in my life. I was like, I could literally do whatever I want. I could rule the world with these 3 Xerox machines. It was the most impressive thing I've ever seen. So like, there you go. That's the fun part of government, is like walking into a room and having access to that much power. There you go. That's how we do things.
That's power. Ditto machines.
You heard it here first, folks. Yeah, that's
it felt like power, so I'll tell you that. So, but no, great show. I've seen a couple. If you haven't seen Umbrella Academy on Netflix, that is a fantastic show. I just got done binge watching it.
What is that about?
Long story short, it is a dysfunctional family where each of the children have special powers, and they basically split up. Like nobody wants to talk to each other, and then the father that adopted all of them from around the world dies, and so they all come home and they find out that the end of the world is coming and that they're the only ones that could stop it. And so and I don't want to give away too much more after that, because it's a lot more than that, but that's the basic premise. But I
know the ending. I think I know how they stop it. Xerox machines.
Yes.
Exactly.
Yes. If only Luther and Number 5 had known about those Xerox machines from the beginning, it would have been absolute a moot point. Power. But it's funny and it's exciting. It's not just like one dimensional. There's not just, it's an action show, or it's everything put together. So I highly recommend the Umbrella Academy on Netflix.
Well, Brad, do you want to give us just a brief kind of background of your medical background, and we'll go from there?
Sure. So I am a general otolaryngologist, so ear, nose, and throat doctor. I went to undergrad at University of Pennsylvania, then medical school at SUNY Buffalo. I'm a New Yorker, then did my residency at Georgetown. And then after Georgetown, I joined the practice that I'm currently a part of, where I'm a partner, called ENT and Allergy Associates. We're actually the largest ENT practice in the country. We are 5 times bigger than the second biggest practice, so we're a big practice.
It's a big Xerox machine.
We make a lot of copies. 43. None of them HIPAA violations, though.
Of course not.
Of course not. So we have something like 43 offices, over 200 physicians, and ENTs and allergists.
Wow.
And I'm a partner there. And my office is on Long Island. So I am in the town's called Garden City, which is right smack in the middle of Long Island, right next to the big mall, just where I always thought I would be spending my adult life, near the mall, near where I grew up. But that's just we're right in the middle. So patients from all over the island have access to us, which is great. And I'm a general ear, nose, and throat doctor. So I see kids, I see adults, I see dizziness, I see hoarseness, difficulty swallowing, sinusitis, sleep apnea, all sorts of stuff.
All kinds of fun things. And so you're a New Yorker. So who's your football team? NFL.
So if we're going to go down this line of questioning, I think it's going to be a bit of a dead end. I don't really follow organized sports.
Okay. No. Okay. With that.
No.
If anything, I watch those like CrossFit movies, which they make. So but that's watching people exercising. That's not really, and they call it a sport. I don't think it's a sport. I think it's just watching someone exercise next to someone else who's also exercising.
Okay. So do you have a favorite CrossFit athlete?
Who's the guy that's the champion?
Matt Frazier.
Matt Frazier. Not him.
Not him.
Not him.
Anyone but him.
Because he's just always so like he could use some PR training. Like when he's engaging with interviews and something, like he could be so much more engaging than he really is and get more sponsorships. And so he just comes off as like a little too gruff, a little too flat, whereas some, like a lot of the other athletes, I think the female athletes, the daughters, right?
Yeah.
All those Icelandic athletes, like they just seem so like they love it, they enjoy it, they're having a good time.
And I don't know what her specialty was, but there was Julie Foucher, and she is a physician, and she was a world-class CrossFitter. So I was like, man, that you have a lot of no extra time on. You have a lot going on. I don't know what to tell you, lady. So on the guy side, it's hard because Matt Fraser is just so dominant. It's hard not to like that. And I think on the female side, even though she hasn't competed in a couple of years, is Camille LeBlanc-Bazinet. I just always, every time I saw her, I was like, hey, maybe you'll marry me someday. And no, that's not going to happen.
Hey.
So, hey, how are you doing? Through my TV while I'm sitting in my lazy boy in my underwear eating an ice cream sandwich. Yeah, exactly. But no, I really like the old CrossFit. Ben, if you had to pick a favorite New York team, let's put this back on Ben then, since he asked this question. Ben, what would you pick? Who would your team
professional football? You mean?
Yeah, sure.
Well, not the Giants, because I'm a Cowboys fan. So it would be the Jets.
The only sport I don't want to touch from New York is hockey, because I'm a hockey guy. And I've seen the Islanders play here, and I was like, damn New York teams, because they're all pretty good at hockey. So I wouldn't be able to pick any New York hockey teams. But
well, it snows like 57 feet up there a year.
Yeah. Buffalo is the north part of the state, right?
Yeah. Well, so I went to med school in Buffalo, and it is an 8-hour drive from where I'm from. It is very far. It's like, Ben, are you in Texas? You're in Texas.
No, I'm in Kansas.
Oh,
he just likes Texas.
You just like Texas teams. Oh, okay.
Yeah.
Because it's like driving somewhere in Texas. Everything's just super far away because the state's humongous. So it's Buffalo's basically Canada to a lot of New Yorkers, because it's right next to their accent is more similar to someone from the Midwest than it is to New Yorkers. We're part of the same state, but it's so distant. The culture's different. The culture's more like the Midwest.
The only thing I really know about Buffalo is the clear and obvious, based on my physique, the chicken wings that you guys made up there. So thank you. The world appreciates your contribution. And
50% hot sauce, 50% butter.
Yeah, I'm going to tell you right now, when I'm having my STEMI, I will be thinking of you the entire time. And I've actually said that during taking care of STEMIs in the ER. I was like, when I have my STEMI, and people are like, don't say that. I'm like, have you ever seen me pass up a chicken wing? Like, it's happening. All right. So let's just prepare and be ready when it comes down. So I have a non-sports question. What led you into ENT?
Good question. So there's a huge variety in what we do. So I think Tom, you do family practice, right?
Correct.
So one of the great things about family practice is you get to take care of people from birth to death, right? You might focus more on one than the other, but still you can take care of everyone, 3 generations of the same family. And so in otolaryngology, we do that as well, right? So I might be doing a 4-day-old cutting their tongue tie in the office and seeing their 80-year-old great grandmother for dizziness and hearing loss as my next patient. So I have a huge variety in age, and then huge variety in the pathology, right? So I might be taking someone to the operating room for sinus surgery, which can be a very technical surgery, and then in the afternoon, kind of like what happened today, might be working that person up for dizziness, which is very challenging medical workup, right? You don't do surgical management of dizziness. I mean, you do, but the textbook maybe, but in reality, people aren't doing those surgeries very often. So, huge variety in what we do. We do a lot of office procedures. We do stuff in the operating room. We work up things medically, and we are the medical management and the surgical management. So it's not like cardiologist and a cardiothoracic surgeon. They have to work together. One's the medical, one's the surgical. Like we're it. So, you're taking care of a lot of stuff from stem to stern.
Interesting. Well, Tom, I'm going to do our social media shout out, and I'm going to let Brad talk about his podcast as well, and then we'll get into our story. So if you like this show, you can find us on Facebook, Instagram, Twitter, and YouTube, all at Just Some Podcast. You can find us on the web or at www.justsomepodcast.com. Our email, if you want to be on the show or you want to just talk to us, admin at justsomepodcast.com. Tom, what else can they do to help us out?
Well, they can stop by the store and look at our merchandise on our website. And while they're there, they can scroll down to the just about the bottom, they'll see a banner for our Amazon affiliate link. They can click on that before they do any shopping or put anything in their basket. And while they're there, they can pick up whatever they want, and they won't even notice that they had us along with them. Anything they purchase will help give some proceeds back to the show, and we would really appreciate it.
Brad, you want to talk about your podcast?
Absolutely. Thank you. I do not have merch, so I'm going to need to work on that. I'm pretty impressed that you guys do. That gives a whole new level of credibility to the show when you've got your own merchandise.
We have stickers.
My daughters love it. They're like, you have merch, I need merch. So
yeah.
So my podcast is called The Physician's Guide to Doctoring, and I named it that so that it would show up more often in search engine if someone looked for physician or doctor.
Well played, sir. Well played.
But as it turns out, it doesn't show up in the search engine that often. So I need your downloads. Please listen to it. I'm a physician, so my audience is basically me. I get people in front of me to answer questions that I would want to help me to be a better physician, community member, boss, to know what I can do in all aspects of being a physician, personal and professional development. But everything that I cover on the show also applies to advanced practice providers. So we have some with a PhD in health economics talking about Medicare for All and the Affordable Care Act. We've had a couple different shows with him, actually. And then we have some specialists on the show, kind of like what I'm going to be talking to you guys about today, specialists talking about what we want everyone to know about their specialty. So what every doctor or advanced practice provider should know about ophthalmology. I've had, if you're a good Samaritan showing up at the scene and someone is not breathing, like, what do you do even if you're like a pathologist and you don't have your microscope on you? So what do you, you're still a provider. What do you need to know in order to be most useful in that scene? Because, your friends and family are going to be looking at you. Look, they're choking, like, do something.
Yeah.
So, we talk about what to do if you have an adverse outcome. Like, how do you recover from that and continue practicing? So a really wide variety of topics. I had someone on the show recently. His name is BJ Fogg. He's been my biggest whale of a guest because he's just been on tons of shows that have much larger followings because he did a lot of research on habits. So how do we get our patients to adhere to their medication? Like he has these little like tricks that he does from his research. He's a PhD at Stanford and just wrote a book called Tiny Habits. So how do you get your patients to exercise more? How do you get them to lose weight? Do all these things that we want them to do, but like there's science behind this that tells us the effective ways to do it. And as it turns out, common wisdom, common knowledge is wrong about a lot of this stuff. He tells us how to do it. So where do you find me? I'm not so good at plugging my podcast because I haven't told you how to find me. So it's Physician's Guide to Doctoring. You can find it at physiciansguidetodoctoring.com. I'm on Twitter at Physician's Guide. I'm on LinkedIn. My name's Bradley Block. Just look me up. And then I have a Facebook page that's at Physician's Guide to Doctoring. I'm not on Pinterest. I'm not on TikTok. I'm not on Etsy. I'm not on Instagram. It's a podcast. So listen to it. Like that's why I'm not on any of those things.
Well, we will make sure that we drop all your links down in the show notes of our show so that if people are interested in downloading, and it sounds like a hell of a show. I mean,
well, thank you.
We'll have to add it to my download. So there's several episodes that sound very interesting. So
I was making notes. I was like, well, what's just things I need to be paying attention to? Let's make sure we hear that. So,
and you guys, because you're funny, you might like, I interviewed the founder of The Onion.
Shut up.
Awesome.
Yeah.
Oh my God.
Yep. He has a school on how to be funny. He's got like online courses and webinars and I think he also teaches at Second City on and he has a bunch of books, how to write funny. His name is Scott Digger. So we talked about how to be funny with your patients appropriately.
Ooh, see,
yeah,
that's the caveat I miss right there.
Yeah.
That I say that and then I'm like, maybe I shouldn't have said that.
He talks about how to recover from a bomb. He's like, you gotta own it. You gotta own it. You gotta say it. You gotta like, I will stick to doctoring, and looks like my comedy career is not going to work out. Boom. Like, and then you can kind of you make yourself the joke, and then the patient will feel a little better about it, and then you can move on. So there you go.
There you go. See, free tip. Thank you, Doc. I appreciate it.
Well, if our audience is interested in getting Tom some of those webinars for how to be funny, send us some money. We'll make sure that we get Tom funnier. So anyway, Tom, you ready to get into our story that you may have missed?
Is it about being funny?
No, but I wish I would have known about that ahead of time because I would have.
I guess I'll try. Yeah, sure.
All right. So, the story that you may have missed.
By the way, Doc, he never tells me what the story is. He just wants to see if I get pissed off during the story. So,
Tom, do you remember
What?
our alcohol episode?
The what?
The alcohol episode.
I remember bits and pieces of the beginning.
Yeah. So smartphones measuring walk could detect drunkenness. There's new research out in the Journal of Studies on Alcohol and Drugs. Authors want to see whether smartphones measuring gait could tell if a person had reached an objective measure of intoxication, a breath alcohol concentration of 0.08, which is the level that people tend to show poor coordination. And of course, for most states is the legal over the limit. So for this study, it was a very small study. They had 22 adults who visited the lab to consume a vodka-based drink that would raise their blood alcohol concentration to 0.02. And then over the next 7 hours, they had them walk 10 steps in a straight line with their smartphone strapped to their back. And in analyzing the data, the researchers found that 92.5% of the time, they could determine that a participant would have exceeded the legal limit of the blood alcohol concentration of 0.08. Obviously, the study does have some limitations. A person's unlikely to keep the phone strapped to their back. Changing location by carrying it and putting it in their bag or a pocket could affect the results. And of course, it's a very small proof of concept study and future research would be needed. But I did like the quote from Dr. Brian Sofiletto, who was the author of the study. In 5 years, I'd like to imagine a world in which if people go out with friends and drink at risky levels, they get an alert at the first sign of impairment and are sent strategies to help them stop drinking and protect them from high-risk events. So I thought it was kind of an interesting story, and we probably needed that night that we had the alcohol episode. But Tom, your thoughts?
Yeah, first is there's an entire journal for alcohol and drugs, and how did we not know about that prior?
Now you do.
Well, now I do, and now I know where I'm applying for a job because I want to know how to get into that. Second of all, yes, we probably could have used that. However, we were sitting and doing a podcast while we were drinking. Obviously, Brad has not heard that episode. Don't. I'll just save you some time. Okay. So it was an unmitigated disaster, which is what we were trying to prove is alcohol can sometimes cause, problems. And last, I think it's pretty awesome. I think that's a great start, but I'm also one of those guys so where does it start and stop? Like, does the phone ring the authorities? Does it shut off my car? Or can you make that an option? Like, hey, my car won't start if it thinks I'm impaired. But then it's like, what if I fell or hurt my knee and I've just had a limp? Okay, now am I not going to be able to drive anywhere for a week? So I think it's a great idea, but I just get weary of my phone controlling that many aspects of what I do next.
Fair enough.
So could be something that's used if you have a DWI, right? Yeah. Then the court mandates that you have this on your phone and but you're right. It has to be specific enough that if you're injured, it's not going to lock you out of your car.
Yeah. I mean, it's a funny idea, but I keep thinking about I was thinking about that while you were saying it. I was like, well, that's great. But what if I have a rock in my shoe and I kind of step funny for a second? It's going to be like, oh, this guy's toast. Mm-mm. And I'm like, oh,
and I already have my wife calling me out on that. She's like, you're drunk. I don't need my phone being like, you're drunk.
Yeah, that's true.
Yeah. I don't need it from you, Apple, and you. So, yeah, that would be a problem.
No,
exactly. You're just proving my point. So, yeah, I hope technology is pretty cool. And like Brad said, perhaps this could be akin to the interlock devices that sometimes are placed by courts or something like that. But it's just the whole idea of my phone making a decision for me. I mean, I've seen plenty of movies where that goes bad. So I'm just saying. It just seems,
that's a Black Mirror. That's a Black Mirror episode.
Black Mirror. Yeah, this is a Skynet problem, and I don't want to open that box. So, but hopefully someday, maybe you can make it a voluntary thing. If you think I'm impaired, ask me, and I have to put in a code or I don't know something, and then there you go from there. Start doing algebra, and if you can't do it, then you're clearly impaired. Well, okay. I'm already not liking that. So that was my least favorite was algebra out of all the math. Anyway, all right. Well, Tom, you ready to get into our main topic and why we have Brad on the show and keeping him away from his West Wing episodes? Yes, absolutely. And I'm actually super stoked. I was making sure I was writing down some stuff. I was like, I want to make sure I ask or we talk about this. So I am ready to dive in whenever you are, Ben. Why don't you start off?
Well, Brad, I guess let's start with, so what are some of the common things that you see in the office, and is often, I'm sure, is probably referred to you from family practice? So what are some kind of common things that you see? I know we kind of talked a little bit beforehand. So
one thing, start with sinus problems. So a common thing that we get referred is someone coming in with sinus problems, sinus infections, sinus headaches, sinus pressure. And something that I want the listeners to take away is that there was a large study, retrospective study, quite a few years ago, but it's panned out in my practice as well. And it's that 9 out of 10 people that are referred to an otolaryngologist from primary care that have sinus pain and pressure have a primary headache and not a sinus infection. So if their chief complaint is sinus pain and pressure, so first I want to give the caveat that you might hear my voice in your ears. This does not make this a doctor-patient relationship. I am not your physician. This is not medical advice. And guys, please don't edit this part out of the show.
No, I wouldn't. Yeah.
Because this is, unfortunately, the world we live in. This is a liability, right? We're taking a risk here. If someone is like, oh, I thought he was giving me medical advice. I'm not. We're all, the audience is providers. So whatever information you glean from here, it's all to be taken within the context of your own medical education. So, sorry. Okay, back to sinus headaches. So sinus headaches, most people, where their chief complaint is pain and pressure, they're actually probably having some variant of a headache, usually a migraine. Other complaints that sometimes go along with that might be something like postnasal drip. Now, postnasal drip is just this nebulous sensation where you feel mucus dripping down the back of your throat. Now, the sinuses and the nose produce about 1 liter to 1.5 liters of mucus a day that drips down the back of your throat, and you swallow it, and that's normal, and that's supposed to happen. That lubricates your food. So just because you feel that mucus might be that you're feeling mucus that's already supposed to be there. You just happen to notice it now. Your attention is drawn to it. So if they're like, well, I get these sinus headaches and postnasal drip, that's not really a great symptom indicator that they might be genuinely having a sinus infection that wouldn't benefit from, say, antibiotics. Now, if they have nasal obstruction and discolored drainage from their nose, now that's a different story. But if it's pain and pressure, even with nasal obstruction, and this is another point, the term congestion I've found to be a very loaded term. It can mean a bunch of different things. It can mean I can't breathe through my nose because it's obstructed. It might mean I feel extra mucus in my nose, which is a different problem. Or it might be that they feel like there's mucus in their sinuses and they're calling that congestion. Now, if they feel mucus in their sinuses, that's sinus pressure. That's more likely to be a sinus headache than it is a sinus infection. So it's important to be able to tease, when they use the word congestion, they might be using it to mean a different thing than you think they mean, or that you would use it to mean. So it's important to tease those things apart if they're describing that sensation. Now, migraines, because it can cause parasympathetic stimulation, can cause nasal obstruction. So you can end up with sinus pressure, a blocked nose, postnasal drip, and actually it's all migraine. And if you have someone where it happens, once a year and you're not sure and you give them antibiotics and it goes away, do they need to see their friendly neighborhood otolaryngologist? It's up to you. I wouldn't say. But if it's a recurring theme in their life, if it's happening over and over, I think it's worth having them see an otolaryngologist, preferably when it's happening, so that we can look up their nose with our scope, see it, maybe get some imaging like a CAT scan. There was a study done on the balloon sinuplasty. I'm not sure if you've ever heard this procedure, but it's kind of like angioplasty, but you stick a balloon up into someone's sinus and inflate it in order to dilate the opening. And this was in our major journal. And they randomized people who were having sinus headaches to balloon procedure or a sham balloon procedure. So they thought they were having the balloon procedure, but they weren't. They just stuck a bunch of cameras up their nose and wiggled them around and told them they had a procedure. As it turns out, most people got better. Didn't matter which arm they were in. Didn't matter. They just got better. So it's being used to relieve this pressure. And usually this pressure happens with a storm coming. It's like your patients with arthritis. They know when a storm's coming, right? Their arthritis bothers them. Well, migraineurs can tell when a storm is coming a lot of the time. So they think that this change in barometric pressure is enough to change the pressure within their sinuses. But that pressure change isn't as dramatic as going up and down in an airplane. So that's more likely to be a variant of migraine than it is to be an actual sinus problem where you need to dilate the opening to the sinuses. A lot to unpack there.
Yeah. No, but that's exactly, I was like, oh, I'm just loading questions in my head.
So what's the big difference then between, say, the migraine sinus headache like you kind of described there versus a full-fledged sinusitis as far as like symptoms that we may see?
So sinusitis is typically going to start off with like cold-like symptoms, right? They might get a sore throat, a stuffy runny nose, a cough. So there's usually a viral prodrome. And the way I like to conceptualize it is the sinuses are constantly making mucus, pushing it out of the sinuses, a lot of ways uphill, into the nose, and it goes down the back of the throat. Now, if you have a cold, it causes the mucosa to swell, and your mucus gets more viscous, it gets more inefficient, and in some people, the bacteria will just multiply and multiply, and that's what turns a viral upper respiratory tract infection into a bacterial sinus infection. So now you've got what used to be a river of the mucus being produced in the sinuses and getting pushed out, and it's now become more of a stagnant pond where you've got like this, gross stuff that's just percolating in your sinuses. So that might give you pressure, but it's also going to give you discolored drainage. It's also going to, it might give you fever, not always that often. It should give you nasal obstruction, loss of sense of smell, cough, sore throat. So other infectious symptoms, and it usually also timing, you can sometimes tell the difference, right? If it's been going on for a couple of weeks, it's more likely to be a sinus infection, although people can have chronic migraine too. So still, don't confuse the two. But so timing can be another piece of the puzzle. It's not like there's any, and that's been looked at. Like, what if I have one major criteria and two minor criteria, or two major criteria and one minor? We can't use those things to like tell someone whether or not reliably that they have a sinus infection. It's a lot of times it's gestalt, but you're going to look for other infectious symptoms that wouldn't be associated with a migraine, like runny nose, sore throat, cough, loss of smell, and sometimes pressure and sometimes not. But I've found pressure, like, you're doing your physical exam, you're pushing on the sinuses. That's not going to tell you, that part of the exam, the pushing on the sinus isn't going to tell you whether or not, because I've seen plenty of patients that they'll push on the sinuses. I feel like I can push the mucus out of my sinuses. Like I'm pushing on them and then I feel like stuff drains out. But like, that's your skull. That can't move so easily. You're not like squishing your skull and mucus is coming out. It's just, they have these associations. So yeah, I can't give you a reliable way to tell the difference between the two, but some good indicators are, was there some viral prodrome? Is there discolored drainage? What's the time length? And then other things like cough or sore throat. And then sometimes I have sinus infection, patients come with sinus infections that just have like cough, like no other symptoms, nothing, just cough. Now that's rare, right? But it's still like I'm saying, like there's no like reliable thing that you can hang your hat on.
So I know this is going to probably sound really dumb, but I get this one a lot in my office. Is somebody will come in, and of course, after 90 hours of minor inconvenience, they think they have a sinus infection. Almost always, by the way, I don't send them straight to ENT, so thank you. But I get this a lot, and I really don't know how to answer it, and I don't know if maybe part of it is wrong. Maybe I have been possibly wrong, as they always automatically go to, I've had some green snot. So I keep hearing you say the word discolored. Usually in my experience, like the lighter colors are clear. Obviously, I'm like, I'm not that worried about it. Is there a significant, like, okay, if you see this, it is probably leading down this road, or is it just, if it's not clear, go a little further?
So one, a lot of bacterial sinus infections are self-limited. So just because it's a bacterial sinus infection does not mean it's not going to resolve spontaneously. Color is unfortunately not a reliable indicator, and anyone who's met any of my children can tell you that they'll get a cold, and because they sneeze and it's just a mountain of discolored snot, just yellow stuff just comes out of theirs, but it's a cold, right? Yeah. Like I don't give them antibiotics. It goes away in like a week or so. So yeah, a discolored drainage or green, yellow is just another piece of the puzzle. But what I would say for someone who's come in after just a couple of days is, now there's a caveat to that, right? Like I've seen people have complications of sinusitis from sinus infections that have been present so like I had a cold and then 2 days later they've got orbital cellulitis from a sinus infection and their vision's being threatened. And, we put them on antibiotics and steroids, and, as long as they are getting better quickly and the ophthalmologist isn't like, we need to do something now, there's pressure on the optic nerve, then we don't have to take them to the operating room, but they do need to be admitted to the hospital and followed and very closely. So time, again, it's just another piece of the puzzle, but not reliable. None of these things is singularly reliable. But yeah, if it's discolored, it's more likely to be a sinus infection, but it doesn't mean that it is a sinus infection.
Good, because that's pretty much the reasoning I've been saying. But then I heard you say discolored a couple times. I was like, wait a second. Have I?
No, I'm saying like differentiating a migraine from a sinus infection, differentiating a cold from a sinus infection is different, and that we're not reliable at. I've seen plenty of patients that have come in to see me for the same thing, and I'll be like, "This is definitely a cold," and then I'll scope them because we have that. It's easy to do. Yeah, it's easy to do in the office for us, and we take a look, and then it's like, oh, I was about to tell you that you had a cold, and lo and behold, you're right, it's a sinus infection. So I'm not, even though this is what I do a lot of the time, it's really hard to tease those things apart. But I think a good rule of thumb would be like, give it a week, as long as they're not in you're not concerned about them developing some complication, they don't have a ton of comorbidities. Just give it a week, because a lot of sinus infections do resolve spontaneously. Not everything needs antibiotics. And if after a week they're not cured, but they're doing better, well, then their trajectory is that they're headed in the right direction. But if they're getting better and then they get worse, well, that tells me that they had the viral prodrome, the virus is making its way out, and now a sinus infection has probably settled its way in.
And I think personally that conversation is a little bit easier the longer that you're seeing patients, as far as like the length of time that you've had that patient. When I first got out and was seeing patients in family practice, it was very hard to tell people they had a viral infection because we live in a pill-based society, and we've discussed that on our show before multiple times. But now, 7 years out, I have the trust of my patients where if I go in and I look at them and I say, no, I think this is viral, they're like, okay, well, it's viral, and then they're happy with that. But yeah, it's an easier conversation to have over time, I think.
I've had patients tell me, why I come to you? I come to you because you never give me antibiotics. Like, okay. Thanks. Sure. All right. But I mean, what they're looking for is like more precision, right? Like because I don't have to, because I can scope them, I don't have to guess as much. Nobody bats 1,000, certainly. I've had patients that I'm like, no, or they might come and it's still viral and then it converts to bacterial. But what I like to do is I like to give them a specific OTC regimen. So like they're coming in because they're miserable, right? And they want to feel better.
Right.
Yes, fine. If I give you Augmentin, you're still going to have a viral respiratory tract infection, and now you're also going to have diarrhea. So rather than that, why don't we just go through what over-the-counters you usually use and which ones I recommend that you use? And because I disassemble those, I deconstruct those cocktail medications. Well, I use Dayquil and NyQuil. Well, why'd you choose those? Well, because it was daytime and then it was nighttime. So I was like, okay, well, what of your symptoms is the worst? Oh, well, right now it's my sore throat. Okay, great. Sore throat. What do we do for that? What do we take? Well, you can use Chloraseptic. You can use NSAIDs. Here's the dosing that you can do of NSAIDs to make sure that you're getting maximal relief. Your nose isn't really bothering you right now, so you don't need any of those other medicines. If you're having trouble sleeping, you can throw a little Benadryl in there. And I always make the distinction of pseudoephedrine. Make sure that they're using pseudoephedrine instead of phenylephrine, because in the United States, they passed a law that says that the pharmacist has to keep pseudoephedrine so that we don't, because that's how they beat meth, right? Congress was like, we don't have a meth problem anymore in the United States because we put it, we had the pharmacists keep track, even though they don't have a mandate in all the states that they have to actually have anything but a written record. So you can just go from store to store, but make sure that they know that they should take pseudoephedrine instead of phenylephrine, because it's a lot more effective for drying up the nose, but don't take it before bed because then it's going to give you insomnia, and don't take it if you have any prostate problems because it's going to put you in urinary retention, and don't take it if you have hypertension because, sorry. So,
I like just letting them go.
Let's
just lay it out, bro. First of all, thank you, because sinus is one of the big things, but obviously one of the big monsters in the room. As a newer NP and working in family, like you said, I see a lot of children, earwax, ear pain, ear infection, like the whole gamut. So I guess my three big things, and specifically for pediatric versus adult, is one, what are some tips for helping people clear earwax when they all have heard, don't ever put a Q-tip in your ear, but so then they're like, well, how do I get it out? And second, differentiating redness on the TM for an ear infection versus irritation in a pediatric patient, because every parent is just sure that their kid has an ear infection and that they need amoxicillin. And sometimes I'm like, I don't think it's an ear infection, but I can't say it's not. And as a new family nurse practitioner, I tend to be proactive. And if I don't know, I'm going to err on the side of caution, which I don't think is a bad guess. But I also, since I am speaking to an expert, what things should I be looking for to make my practice better?
Okay, so I actually lecture, there are pediatric residents at my hospital. And so some of them rotate with me, and I give them like 2 lectures a year, one on ears and one on pediatric head and neck infections. So I've spoken to pediatricians frequently about this. And the first is, it's just hard. It's hard. A good ear exam on a kid is hard. Now, you have the benefit of being able to see adults as well, so that just helps you with your chops, right? Like just recognizing what a normal ear looks like in someone that isn't screaming and wiggling, so that you just get accustomed to normal ears and normal ears and normal ears. Number one is make sure that you have a otoscope that is fully charged, has a light bulb that isn't dim, and that you're using the largest speculum you can. And the reason is not because you want to get the best view of the drum, that's advantageous, but the largest speculum is also going to let the most light in. So the more light, part of the problem, especially with newborns, is you got to use that little 3 millimeter speculum to be able to see, and barely any light gets through. So it's really hard to see something that at the end of a narrow tunnel with a dim light.
Yeah.
So make sure you're using the biggest speculum, make sure that your otoscope is fully charged, and make sure that the bulb isn't dim. So make sure your equipment is good. So that's the key to a good ear exam. When you're trying to differentiate between like, is it just red or isn't, that's hard. I don't really have a good answer for that, other than having looked at like hundreds of thousands of ears, because sometimes the kid's screaming, and what's going to happen? The veins in their face are dilating, including the ones on their eardrum. So their eardrum looks red. It doesn't necessarily mean that it is an ear infection. It's just, I really don't have any tips, except if you can, get a tympanometer.
Okay. So
a tympanometer is going to tell you about the eardrum movement. It's not a hard piece of equipment to learn how to use. And I'm not sure how billing works for you in your state or your practice or, the degree, but generally it pays for itself, depending, how many people you see, anywhere from 6 months to a year, it'll pay for itself. It's not a lucrative procedure. You might get like $15 for doing a tympanogram, but it's going to take a lot of the guesswork out, because if the eardrum is moving normally, then there's no ear infection, right? Because the eardrums, there's no fluid. There's no fluid behind the eardrum. How could it be moving normally? Or if it's retracted, maybe they had fluid, it's resolving. So generally it's going to be flat, it's called a B tympanogram, the eardrum. So what a tympanometer does is it's like a standardized way of doing pneumatic otoscopy. So instead of squeezing that little bulb and seeing if you can see their eardrum moving, you don't have to be looking at the eardrum. You just put the tympanometer in, the tip seals with their drum, it puts a little bit of pressure in, and the eardrum is going to move. And then it gives you a reading on that. So you're going to be able to glean from that, is there fluid or is there not? Although sometimes with a bulging drum, it's going to move, it's going to look a little different. So you need to be able to interpret those results. You also need to be good enough at the exam to know when the thing isn't working. Because it certainly happened to me from a time to time where it's told me that the eardrum is not moving, and I'm looking at it and I'm like, what the hell? This is a normal eardrum. This is just like, I'm trying to check my work just to make sure I'm not missing something, or it's like a follow-up on someone that had maybe a perforation or something like that, and I'm doing that, and it might not be reliable. But what's going to happen is your ear exam is going to get better, because you've got this thing that's double checking your work, and it's going to tell you you're wrong. And then you're going to take another look at the ear and go, oh yeah, okay. That's what just a screaming kid although if they're screaming, sometimes that interferes with the test. So, it's like having another voice in the argument. It's like having another piece of the puzzle, like this tympanometer. So that's my advice, is if you can get one of those, if you're someone that sees a lot of kids, it's going to take a lot of the guesswork out. The older kids, you can do a tuning fork test, right? And it'll get louder on the side that has fluid, but they've got to be a reliable kid, right? The earliest you can ask that is like 6 years old, I think.
Yeah, I can see that.
Those are the kids that are already like not having as many ear infections, right? Peak is like 2 to 4. and they're not going to be reliable enough at that age.
And just one quick follow-up, because I see Ben, he's getting ready, but the next inevitable down that road is they're like, well, does he need tubes? And I'll be honest.
My question. So.
Yeah, I would say, to be fair, I honestly go, look, we're not at the, if I think we're at the point I'm referring, then that's one thing. But I usually just go, I'm going to just let the ENT specialist determine that. I don't ever tell someone like, oh, he definitely, I've never said that. Is there a certain, and again, I don't want specific criteria because hard and fast rules rarely work, but is there a general rule of thumb for family nurse practitioners that you want us to know before we refer that child or patient we think may need a PE tube to you? Like, is there a criteria we should really be trying to use before we ship them to you?
I mean, I can give you the American Academy of Otolaryngology guidelines, and I'll just jump off from there. It's 3 infections in a 6-month period or 4 infections in a year, and then an abnormal exam when we see them. So what happens is sometimes it might be a situation like you described, Tom, where you might be overcalling it because it's a hard diagnosis to make. And so we need to see them. I also have the advantage of having an audiologist in my office that does a hearing test on them. So I have like a whole lot more information at my disposal when I'm making, like I might be looking in there and be like, oh, yeah, that looks fine. And then they come back with a conductive hearing loss in the hearing test. I'm like, oh, looks like I was wrong. And then, I change my decision. So I mean, I think it's important to have some humility, right? All of us when we're doing an exam that we know is challenging even for me who does this all the time. So it's 3 infections in 6 months and 4 in a year, but that's like my minimum. That's my minimum, unless they have like a speech delay. More often, I'll do it for fluid that doesn't go away. So if you see a kid that has an ear infection, you see them a couple weeks later, you make sure that the fluid's gone. If the fluid's gone, fine. If the fluid's not gone, maybe wait a little longer, another month. And then if it still hasn't gone away, then send them over to us, because I'm much more likely to do tubes in someone where the fluid has failed to resolve than for recurring infections. Because a lot of times the recurring infections happen in people that the fluid fails to resolve. So they're getting infection, the fluid's on its way out, and then they get another infection. And then the fluid's on its way out, and then they get another infection. So the fluid never really goes away. So that's, to me, more of an indication than the recurring infections. Because if they have like a lot of infections, but the fluid goes away like that, well, that tells me that their eustachian tubes function pretty well. And they're not likely to actually have that many infections. Because why would they? Because their eustachian tubes work really well. So it's more going to be fluid that fails to resolve than recurring infections. But the number that you're looking for is 3 in 6 months or 4 in a year. Then you're going to refer to us. And I appreciate you putting it that way. You're sending to us not to get tubes. You're sending us for an evaluation. So I'd much rather you send me too many patients than too few, right? Because if you're sending too few, then we're missing patients that would be benefiting from tubes. If you're sending too many, then all you're doing is you're reassuring yourself and the family that you're doing the right thing by just watching.
Now, is there a difference in treating an acute otitis media once they have tubes in? Like, do we still do oral antibiotics? Do you do drops instead of antibiotics? What's the difference on that?
If they have tubes, drainage from the ear is treated with drops, because now you have a conduit to get something that doesn't have systemic side effects directly to the site of infection. So if there's drainage from the tubes, you want to treat them with drops. I've heard some debate about this, right? Is it an ear infection? Like sometimes you'll just have a kid who's super snotty and some of that mucus is just taking the path of least resistance. So it goes up the eustachian tube, out the tube, out the ear tube. So it's not technically an infection. Or is it? Like, of course there is. There's drainage from the ear. Of course it's an infection. I've heard fellowship trained pediatric otolaryngologists argue both sides of that. So, but either way, it doesn't matter. There's drainage from the ear, put them on drops, get rid of the drainage. So yeah, you don't necessarily need oral antibiotics unless they're having some complication. There's some other reason you might want to put them on oral antibiotics, but if it's just uncomplicated drainage from the tube, it almost always goes away with drops. You just don't want to use cortisporin. Don't use polymyxin neomycin, because neomycin is ototoxic. It has to be ofloxacin, ciprofloxacin, one of the quinolones. It can't be neomycin.
Now, is that with the tubes, or like an otitis externa, like a swimmer's ear, do you still use the neomycin there? Or
yeah, you can use that as long as they have an intact drum.
Okay, I just wanted to make sure.
But if you're not sure, then don't put them on neomycin. Like I've seen some people where they end up with an otitis media. It drains into the ear canal, macerates the skin, leads to an otitis externa. So now they've got otitis media and otitis externa. But if you can't see the drum to be able to tell that there's no perf, then you're not going to want to put them on neomycin.
My last big ear question, then I'll turn back over to you, Tom. Where the hell did the numbing eardrops go, and will they ever come back?
No, they're gone. The benzocaine, antipyrine drops. Yeah,
Yes.
I think those have been gone for like 5 or 10 years.
Yeah, it's been about 5 years. I used to ride them when I first got out, and parents loved them, and now it's, yeah.
So one of the reasons that they're gone, I think, I don't know, I wasn't part of the legislation on that. I didn't part of the FDA. But I think because if you're using those drops, then you've missed the diagnosis. Like there's never a circumstance where I've been like, oh man, I wish I had those drops. Because you want, if you have otitis externa, you need to be using and they're in a lot of pain. Yeah, fine. Have some steroid containing antibiotic drop so that it treats the inflammation and the swelling and the infection. But a lot of times earaches. So let's get into something else that I want you guys to be aware of. Earaches in the setting of a normal exam. So I'm seeing a ton of right now, TMJ. So people are coming in with ear pain, feeling a fullness in their ear, feeling a fluid in their ear. They feel like they might have even lost some hearing. Now we can test it. Like I have the advantage of being able to test them for that, right? So we get a hearing test, examine them, and it turns out they're grinding their teeth. Why are they grinding their teeth? Well, because we're in the middle of the biggest pandemic that the world has seen in 100 years, right? So, people are out of work, people are sick, people are scared for so many different appropriate reasons. And so what are they doing? They're grinding their teeth. They grind their teeth, they end up with TMJ, which causes ear pain, and they end up in my exam room. So that's always something to keep in mind. You want to put your hand, if you look in the ear and you're like, this looks like a normal exam. What are they talking about? Put your fingers over their TMJ and have them close their mouth a couple of times. The TMJ and the ear canal share a common wall. That's actually one of the reasons I think you were going to ask about the earwax thing. One of the reasons that wax extrudes by itself is because the movement of the jaw causes the wax to kind of rifle its way out of the ear canal. So
Interesting.
Yeah. So chewing is what moves the canal wall, which moves the wax out. So don't mess with the ear canal. I'll take that as a segue to talk about earwax. Everyone's favorite subject, my favorite subject. But one of my favorite things to see in the office, oddly enough, it's just so cathartic. They're like, I can't hear. And you're like, okay. And then you're like, I can hear again. It's a miracle. You're amazing. And it's just like, you just flicked a little wax out because, very, very fulfilling visit for everybody. So the teaching is don't put anything in the ear that's bigger than your elbow. Okay, fine. What I tell people is clean your ear like you clean your bottom. Just wipe the outside. Don't.
I was going to say, how am I going to get toilet paper in there?
Yeah.
Like, where are we going with this?
You're just wiping the outside because your body has a system for making wax and pushing it out. It pushes it out, pushes it out. If you mess with that system, one of a couple things is going to happen. Either you're going to push it in, you're going to end up with impacted wax. You could scratch your ear canal. You could puncture the drum, although that's pretty rare. Or you could be very successful at it. You strip away all the wax, and now your ear canal is really either itchy because it's dry or susceptible to infection because wax is bacteriostatic and a waterproofing agent for the canal skin. So you've stripped that away, and now you get swimmer's ear. And swimmer's ear is a painful skin infection, not what most people think it is, which is my ear's clogged and I can't hear. No, that's just earwax. Swimmer's ear is a painful, you guys know, otitis externa. It's a painful skin infection. So don't use Q-tips because it's going to put you at risk for otitis externa, among those other things that I mentioned. So just leave it alone. And when you're washing your face, take a little swipe at your ear. If there's a big glob of wax, then you'll get it. And if not, leave them alone. Same thing. Same goes for your kids. Leave them alone.
So in our office, we used to use the water pick. That's what we used to use. And then about a year ago, I switched to the elephant ear, which is like the spray bottle that has the plastic catheter on it. And that's so much easier. It works 100 times better. But what's your kind of go-to for impacted wax?
So, we have the advantage of having a lot of toys at our disposal, right? Like I have a microscope. I have loops that I use. Like I use my OR loops in the office for examining people. So sometimes I'll use my loops. I've got suctions. I've got curettes. I've got forceps, and really depending on I see it so often that like you'll look at wax and you'll be like, that's looks like the curette. Or like I'll loosen it off the canal wall with the curette and then grab it with the forceps. Or I'll use the suction, and if there's a little tenacious stuff on the drum, then I might irrigate it out afterwards as well. Like, you end up a lot of tools. So it really depends on the tolerance of the patient, the texture of the wax, the shape of the ear canal. So it depends on a lot of those things. But sometimes even I struggle with wax. Like I'll have someone that's like, in my chair for a long time as I'm like wrestling with it. I'll end up being a sweaty mess afterwards from earwax.
So you're wrestling that wax.
But yeah, it happens.
I just had this funny story because we have curettes and elephant ears at our practice. And I just imagine Brad coming in here and be like, what are you, a caveman? Like, this is all you have to work with? Like, how am I going to remove wax with an elephant ear and a curette? I'm like,
no, but the curette, I mean, you can kind of like get around it and scoop it out, but I think it also depends on which otoscope head you have. There's an otoscope head that's called an operative head that has a little like magnifying glass on it, and that's the only thing. So you can get your instrument around it a little better. I prefer that one, but it also, rather than the one with the little window that you swing to the side and stick your instrument through, I think that's a little more restricting. I mean, you can also try using like a headlight to look in the ear so that you're just looking right at it. That way you're using both eyes. So you have depth perception. When you're using one eye to look down an otoscope, you don't have depth perception, so makes it a little harder.
That makes sense. Tom, anything else on ears? I know we're kind of getting toward the end, but I wanted to make sure we hit on dizziness because that's everybody.
Dizziness, yes. I was hoping you would talk about that.
But Tom, do you have anything else for ears before we jump into that?
No, not on ears.
So dizziness. We all hate dizziness.
Oh God, I hate
97
dizziness.
different things. So let's talk dizziness.
Okay. So first, a little primer on how the labyrinth works, the membranous labyrinth, right? And the semicircular canals. So an easier way to conceptualize how they work is they give you information about rotation. So if you're turning your head like you're saying no, or you're turning your head like you're nodding yes, or you're turning your head, I don't know how to describe it, but like kind of like tilting your head from side to side, those are the three dimensions that your semicircular canals are giving your brain about your head movement. And vertigo is not a diagnosis. Vertigo is a sensation. Vertigo is the subjective sensation of room spinning. So if you tell your patient that they have vertigo, that's tantamount to telling them that they have a stomach ache. Like, they know, my stomach hurts. Thank you for telling me that. I know. So a lot of times what people think, I think when they're saying that the patient has vertigo, is they think that they have benign paroxysmal positional vertigo. So in benign paroxysmal positional vertigo, classically what happens is they lie down and they turn to one side and they feel the room spinning around them anywhere from a couple of seconds to a minute. It can happen with bending over, but it happens with bending over, but classically it's lying down and turning to the side. Sometimes when people hear like, oh, it happens when I stand up, and they think, oh, it's positional, and the patient's dizzy, so it's positional vertigo. No, that sounds more like autonomic dysfunction than dizziness. If they're like, maybe they're beta blockers, a lot of things, the POTS syndrome, there are a lot of things that can cause dizziness there. But within the world of otolaryngology, there are really only a finite number of disorders. There's benign paroxysmal positional vertigo that we just mentioned, and you diagnose that with a Dix-Hallpike maneuver or some modification thereof, because that's really for the posterior semicircular canal. And we really don't need to get into the weeds with this, because if you think they have benign paroxysmal positional vertigo, just send them over to us, right? And then we'll be able to diagnose it and treat it. It's one of my favorite things. It's actually one of the reasons I like dizziness, if it's that diagnosis. A lot of times dizziness is it's hard to know who to send them to, right?
Oh, yeah.
But I would say if it's room spinning, then we're a good start. But it has to be genuine room spinning. If it's like, well, I'm off balance, I'm kind of foggy, that's much less likely. So there's benign paroxysmal positional vertigo. Then there's Meniere's disease. And Meniere's disease is another that will give you true vertigo. So room spinning, it typically lasts for hours at a time and is associated with low frequency hearing loss, ear fullness, and a roaring sound. But it doesn't have to be all of those at the same time. But generally, at least two of them to get a diagnosis of Meniere's disease. But again, that's room spinning. Or it could be vestibular neuritis. And vestibular neuritis, you'll end up with anywhere from hours to days of room spinning. And this is really debilitating. And the only thing that'll make them feel better is typically benzos. And that typically gets more of a workup too. Like, because those patients they can't get out of bed. Because it's just, imagine feeling the room is spinning for days. It's horrible. And then afterwards, they end up with fatigue of their semicircular canals. So they feel off balance, because now the thing that's supposed to be telling them that when their head is moving isn't. So they're just off, and it can be really debilitating for months if they had a severe enough episode. So that's just a quick primer on otologic causes of dizziness. It's important to really get the history of, does it happen when they lie down and turn to the side, or even lie down at all? Does it happen with bending over? And is it true vertigo? So that's BPPV. And then if there's other ear symptoms associated with it, fewer hours, it's Meniere's. And then labyrinthitis and vestibular neuritis are similar, except labyrinthitis is associated with hearing loss as well. So they lost hearing and they are experiencing vertigo. And those things we should definitely be involved in, we should be involved in the care of all of those things. And certainly the sooner the better.
Lead me to one kind of final question before we start wrapping things up then. So what are some definite big things that from a family practice standpoint, we need to be getting an ENT involved as soon as we can?
Don't let hoarseness go for too long. I mean, a lot of times it's not laryngeal cancer, but it can be very easily, and it's pretty easy to diagnose, when we scope them. So if they have persistent hoarseness for more than a couple of weeks, you want to send that over. Firm neck, I'm thinking of the cancer stuff, right? Like
right.
any firm neck mass, changing their voice, those types of things you want to send to us sooner rather than later. It could be a parotid, it could be a lymph node, base of tongue cancer, tonsil cancer. Those will sometimes present as neck masses because it's already metastasized to the neck. So if you want to try antibiotics first because you think it might be infection, fine. But if it doesn't respond, don't sit on that. Send that over.
Well, one of the things that I was going to ask, and I'm really glad Ben brought this up, is because in my area, there may be stuff. I try and take care of what I can in the office, but I also know my limitations, and I'm like, nope, you got to go to ENT. But it is very difficult for us to get our patients into ENTs. Like sometimes there's a wait. So that's why I think I'm being super intent. And I hear you say stuff like send them over sooner than later. I'm like, oh, I would love to.
Yeah.
But this may not be something. So
we don't have that problem in New York. So there are a lot of us. So we have access to care is great.
So assuming that you're in a more rural area, what are some things that I might be able to do to help you out when you see the patient? Like, is there a CT of the neck you want done? Like, what things could we possibly do in the office to set this patient up for success when they finally get to see you? Or just send them to you?
Yeah, I mean, that's a tough one. That's a tough one because, like, you really need tissue to make a diagnosis. I mean, you're going to want to get a CAT scan of the neck and chest. They may end up needing a PET scan. We're gonna want to get tissue. And truth be told, I actually don't manage cancer anymore. I send that to one of the advantages of being in New York is I have easy access to world-class academic institutions, right? I'll send them over to Mount Sinai or Columbia Cornell or NYU, or, where these guys just do head and neck cancer. Like that's all they do all day long. So rather than me dabbling in it, I will send someone over to that. So I don't know if I should really weigh in on things that aren't really part of my practice anymore. I would say there's things that we discussed. If you want to get a CAT scan of the sinuses without contrast, if you're not sure, is it a migraine, is it a sinus infection, then a CAT scan of the sinuses without contrast would be helpful for making that distinction. I'm trying to think of other things that would help.
Well, already that's super helpful because that is one of those, especially this time of year getting ready to come up, are people that I am just sure that this is what I have. And I'm like looking at them, I'm looking at their symptoms. I'm like, no, none of this is really fitting the sinus infection, but it's been recurrent. So I don't want to not treat them, but I want to make sure I get the right treatment. So at this point, I might be a little more willing to go, let's go with the CT of your head and sinuses and let's see what we can find out. So, but
that could be a little hairy too, because sometimes like if you're trying to just make a distinction between a cold and a sinus infection, like they're going to end up with a lot of mucosal thickening in their sinuses on a CAT scan a lot of the time, which might lead you to believe that they're actually having a sinus problem, like a bacterial sinus infection, whereas they're not. So, sometimes you'll end up with some abnormalities on the CAT scan that will be called out by the radiologist, but I might look at it and go, no, this is actually more of a variant of normal because the mucosal thickening isn't that. There are no air fluid levels, which tells me that there's no actual pus in the sinus. It's just mucosal thickening, and it's really not that bad mucosal thickening. So this is probably just a variant of normal. So, being able to interpret those within the context of the symptoms is also important. I mean, it seems like you're hamstrung in that situation. I don't really have a great answer to that. But yeah, if you're going to send them over, getting the CAT scan first might be helpful. But if they're going to scope them, maybe it's not the right time. It's hard to tell.
And again, sometimes I don't have the luxury, and I'm sure Ben's in a similar position. I don't always have the luxury of, well, I'll just send you to ENT. ENT is going to be like, well, did you do this, and this first? Because they're overwhelmed as well. So if that's something I can do, and also on top of it, I like that you basically indirectly stuck it to radiology there. Like, You guys don't know. Like, get off that radiology. Could be this, clinically correlate that. Yeah, I got it. So
well, they say that with the ears too. Like they were like, well, yeah, there's fluid in the mastoids, and then I get called, this patient has mastoiditis. Mastoiditis is a clinical diagnosis. Like they're gonna have like their ears going to be proptotic and sticking out. There's going to be swelling and redness behind it, like tenderness over the mastoid. It's not just fluid in the mastoid, because you have a cold, you'll have some, it's kind of like mucosal thickening in the sinuses, you'll have some fluid in the mastoid. But they have to call it because it's not totally normal. They have to read what they're seeing, but it doesn't necessarily mean that it is the diagnosis.
Yes, that's always fun a couple of times as a new nurse practitioner when you're like, what? Like that's not what I was expecting when you guys gave me this call. So that's always a fun day for the new NP.
Well, how about this? What's the weirdest foreign body you've pulled out of an ears or a nose?
So one that's more common than people would think, it's a couch cushion. So kids will take unzip the couch like cushion, take a little of the foam and stick it up their nose.
Huh.
And it stinks like death. It's horrible.
Oh, I bet.
It is such a horrible smell. It is, yeah, it's terrible.
Cushion with a million farts through it, and you just stuffed it up your nose. Yeah,
kids do funny things.
I would not have. I was expecting Legos.
Yeah, that's where I was like.
Yeah, like
beads and bugs.
Yeah, exactly.
Stuff like that out. Yeah.
Couch cushion was not on my list of things I was expecting you to say.
So you can flush a lot of things out of the ear, like a lot of foreign bodies out of the ear. But please, if you see a bug, don't flush it out of the ear. Just
what do we do?
They have their little legs hang onto the ear canal, and it makes it. You got to be able to like grab them, and they inevitably like fall apart. Like you need a good look and a good instrument. And sometimes, if you're trying to irrigate it out, it'll irritate the canal skin. It'll make it swell. It'll make it more tender. It'll make it harder to get it out. So bugs, you got to be precise about, but other things, a lot of times you can flush them out of the.
Honestly, that's a great, like, next time someone's going to be like, I think there's something here. I'm going to be like, it's not a bug because you don't flush bugs. Like that's Tom's rule of thumb. He's an ENT expert in the office now because he knows don't flush bugs.
Don't flush bugs.
But if you don't have access to an otolaryngologist and you don't have, I'm not giving you a good solution other than send it to your friendly neighborhood ENT.
I don't know what the solution is, but I know it's not flush their ear. So I'll figure it out from there.
All right. So we'll get into our final segment so that Brad can get on with his evening. So Brad, we do a segment with every guest on our show, and it's a segment that we call 5 Questions. Join us on a journey into the inner psyche of our guest as we ask 5 questions.
He looks apprehensive, so I'm just saying.
Not bad.
If it has anything to do with professional sports,
Nope.
So basically, I don't know if you ever watched Inside the Actor's Studio with James Lipton. So he used to ask the same 10 questions to every guest. And so that's kind of what it's homage to that. So we ask the same 5 questions to every guest, and it just kind of gives us an idea of into your inner psyche. So it's fun. So I asked the questions.
Fruit Loops, peanut butter, and a jump rope.
Well, there you go.
See, I love this game already. There you go.
So basically, I ask the questions, and Tom cracks jokes about your answers. So
it works. So,
question 1, Brad. What is your favorite medical word?
Sphincter.
Ooh, the classic.
Yeah. Good one.
There's like a Wayne's World reference in there.
Exactly. Sphincter says what? Yeah, exactly. You can't go wrong with that. I probably said that a million times in my life. So
it's a good one. All right. Question 2. If you could do any job in the world other than what you currently do, what would it be?
I think maybe architect. Yeah. It's not a funny answer. It's not an exciting answer. It's not even that interesting an answer. But like if I had to do it all over again, what would I do? Like, spatial relations and, there's some creativity involved in that. You got to be able to work with other people. Not that I'm the best at that, but, team building and things like that. So there's a social aspect to it. I think
architect would be kind of cool because especially if you design something.
Yeah.
And then you like drive by it like 10 years later, you're like, that was I came up with that. I could see that.
The guy who designed the museum in Spain, Frankel Wright, like some of the stuff like an architect can do is just fantastic.
Oh yeah.
Though every time I hear the word architect, I think of George Costanza. So that's a problem. And then the second thing was I was really hoping you were going to say professional football punter, like something like that. Like, oh, you got me. I wasn't expecting that. So
no, it's another academic type job that's cerebral and not that exciting. Not like an acrobat. I would be in Cirque du Soleil. I would be a professional gambler. I would be, I don't know, what are all the exciting things?
A professional gambler
would just not have the
if you ever want to go to a casino, Brad, you let me know, because if there's one thing I know how to do is win just enough to make the pit bosses suspicious, and then they come over to the table, and then it makes all my friends really nervous. So of course I'm drunk, so I don't care at that point, but it's a great time for me. So if you're ready, you let me know. So
I actually had on my show Blake Eastman. He started the first brick and mortar poker school. We talked about nonverbal communication. Now that we're all either over telehealth or behind the mask. So I actually had him. He's a professional poker player.
Another episode I'm going to have to listen to.
Exactly. I'm going to be listening to
I'm going to be like binge listening to your show, I think.
I hope I see those downloads spike.
You hopefully you will.
I'll know who's listening.
There you go. Yeah. All right, Brad. Question 3. I want you to think back to your first car. Was it a stylish ride or a rolling turd?
Rolling turd. It was like my parents' old car. Although the first car that I ever bought, Pontiac Firebird.
Hey, yeah, there's nothing wrong with that.
Yeah.
Did you?
2001,
what year?
the last year. 2001 was the last year they made it. Like, it wasn't like T-tops or anything like that. It was a convertible, and it was when I was a resident. So I was so miserable that the only pleasure I got during my day was to drive to and from the hospital. So I got a convertible so I could drive to and from the hospital with the top down. And it was, the best part of my day.
It's awesome.
And I legit was going to say T-tops. I was legit. That was like the next question out of my head. And then you took it out.
Sorry. No T-tops. It was no turning radius. It was all hood and windshield. So it was it was a huge car, but there was no room for people. It was completely fuel efficient. It was like 2 inches off the ground. So if it snowed, I was immobile. It was the worst decision for a vehicle, especially as a resident. But
it was fun. There it is. So that's the end.
Pontiac.
It's hard to make fun of that because he started off with, I was a turd. I'm like, no. My favorite's when they're like, no, it was great. It was an 88 Caprice Classic. I'm like, no, you're wrong. You're wrong. This is how it goes down.
All right, Brad. Question 4. If your house is on fire, everyone, including your pets, are safe. Other than pictures, what's the one thing you want to get out of your house?
My laptop. It's got all my podcast interviews on it.
There you go.
See, that's the podcast.
Because I'm an idiot. I don't have my stuff in the cloud. It's just on my laptop. So if my laptop craps out, I'm hosed.
I understand. I edit this show, and that's where all my stuff's on my laptop. So I need to back it up into the cloud somewhere, but I haven't.
Gotta have priorities. I'm not pictures. Well, pictures are all in the cloud, right? All the pictures of my kids and stuff.
That's everybody's answer, so we had to take that answer off the board.
Yeah.
Yeah.
I don't know if there's anything else of value in my house that I can think of. Like
the laptop. That's good. All right. Question 5, Brad. You have $9.18 in your pocket. You're at a convenience store. What all do you buy?
This is crunch time, Brad. Crunch time.
I need some context. Like, what time of day is it? Am I on a road trip? Am I going somewhere?
No.
I don't get anything.
$9.18.
Is this like 20 years ago? I'm in college. Nope. It's the middle of the night. I'm really hungry.
Tomorrow.
Yes. Tomorrow, 2020.
Tomorrow. Oh, God. I'm so boring. It's going to be like chocolate chip cookies and a coffee or something. Like, that is a go-to. I know. Look, compared to some of the answers we get where it's, I want a protein water and some kale. I'm like, no, you are done, madam. Get off my show. No, I can deal. How do you take your coffee? Here's another I want to hear. How do I take my coffee? Okay. Now you're going to get a whole thing. My wife and I are kind of coffee snobs. We actually cold brew our coffee at home and then sweeten it with a little maple syrup and whole milk.
I want to do that so bad now. Like,
it's easy. You get one of these mesh bags that they use for, like, people make their own almond milk or something. That's nice. Yeah, those kale
That's
people
just
probably make
horrible.
the almond milk.
Yes, the kale people
but
are
it's like
terrible.
these like the really thin, really small holes in the mesh bag so that the coffee grounds don't get through. You grind your own beans. We found it's best with espresso beans, and then you put it in the bag in the water overnight, and you can have your coffee for the week. So you don't have to like make it every single day. You just like pour it out of the pitcher because it stays for a while. And that's so we have cold brew. It was from homage to the coffee place that was next to our first apartment. We used to live in Long Island City, Queens, and they had this stuff called Rocket Fuel, which was cold brew with maple syrup and whole milk.
Syrup sounds
delicious.
You had me at Rocket Fuel.
Yeah.
Well, let's look at me. You had me at maple syrup, okay? But I mean, for cool points, Rocket Fuel is definitely the way to go.
But there's something about the maple syrup that just adds something to the coffee that the sugar doesn't. It gives a little more depth.
Yeah.
interesting.
Well, I certainly I can get along with a coffee. I wish I drank it more, but I'm too lazy in the morning to always get coffee. So sometimes it's just, a Diet Pepsi, but my wife and I really like coffee. So the next time I need some kind of caffeine first. I just reach around until I grab something. That's what I drink. Of course, sometimes it's almond milk. Joke's on me, but no, I'm kidding. So I think my wife and I, when we do have time, we do make some pretty good coffee, and I'm going to be like, hey, you know what I heard? Maple syrup.
Maple syrup.
That's the key. So, all right, everybody that's out there listening. By the way, Brad, I'm sure you have around it cracks me up that there are people in Uruguay and China and everywhere downloads our show. So I'm hoping somebody right now in Portugal is going maple syrup.
Maple syrup, yeah.
Maple syrup. Like it's just mind blown. Someone's drinking maple
sardines because they love sardines in Portugal.
Someone in Germany's like, put down the beer and pick up the syrup, my friend. Like it's time to get on this. So I'm excited. I really want someone to tell me about Bjorn. Probably drinks maple syrup in his coffee. Probably. So it's time to push us forwards.
Bjorn, I was just like the number 7 medicine podcast in Sweden. Have you seen those? Like on Chartable.
Yeah.
You're like, I was like number 16 in Taiwan for like 2 weeks straight. And now I'm completely off the charts there.
No,
America, not so much.
I used to get excited and I would text on like, dude, we're like number 123 on, in Venezuela. And it's like, and now it's like, I think we were up to like 16 in Pakistan like last week. And I'm like,
yeah. Oh no.
This seems
Trust
odd.
me, because he said to me like screenshots of this, and then I go, is that good? I don't even know anymore.
Yeah.
Like my center of objectivity to this have now completely changed after doing it for 2 years. I'm like, I don't know if
where do you think Joe Rogan is in there? Where do you think Joe Rogan is in?
He's number one everywhere. Like God, that guy. And here's the thing that cracks me up, because we do an hour show, and I'm like, man, this, it's semi-work intensive, more for Ben than I, but he does 3-hour shows like multiple times a week. I'm like, what is this guy doing?
Teams of researchers.
So he walks in.
This is his job.
I know, but
he walks in. He bullshits for 3 hours. He walks out. Everyone else is the one doing the editing. All the stuff.
Fair enough.
Stuff in the background.
I don't know how we get to that. Yeah,
he's a stand-up comedian, and they like it's a skill that they have that they've trained to do from just doing thousands of hours of on the stage, figuring out what works and doesn't work. It's they get practice. They get good at it. So his stand-up on Netflix was awesome.
Yes, I really like him, and Tom Segura is probably one of my other ones I listen to a lot. But I don't know how we get to that level, but when we get there, Brad, we're
with you.
Like, yes, we're bringing the Brad train with us. So you know why? If nothing else, because every day I'm going to be like, I'm drinking coffee. You know what's in it, Ben? Maple syrup. So they're
wrap this episode up before it's all syrupy. So if you like our podcast, of course, you can find us Facebook, Instagram, Twitter, YouTube, all at Just Some Podcast, websites, www.justsomepodcast.com, emails, admin@justsomepodcast.com. Brad, why don't you tell them about your podcast one more time?
Physician's Guide to Doctoring. It's geared towards physicians, so it's also going to be applicable towards advanced practice providers. So please check it out, physiciansguidetodoctoring.com, at Physicians Guide on Twitter, Physicians Guide to Doctoring on Facebook, or just check me out, Bradley Block, on LinkedIn.
There you go. We need to get each some merchandise, though. We'll talk about that.
We'll
Work on the merch.
So, all right. Well, hey, on that note, we're going to wrap this episode up. Thanks, everybody, for joining us. Brad, thank you for agreeing to come on and educating us on some important topics on ENT. I'm sure that we will come up with some other topics and we'll have to hit you up and have you back as a return guest.
That'd be great. Next time we'll do throat clearing.
Oh,
Yep, that's a big one. That's a big, really, it's a big one. It's a big one. Ben and Tom, it's been a lot of fun. Thanks so much for having me.
it has been great.
Hey, on that note, I hope everybody has a great week.
Hey, everybody, stay safe out there. And I'm just saying, every guest been
just to pass the time. Lately, I see why